Thank you so much. I'm going to share my screen to thank you for the invitation and looking at your list of people who've spoken here before. In fact, I think I've spoken here a while ago. It's an honor to be included among those people. So what I'd like to do today is walk you through a bit of the process, how we reached the consensus that we reached, and then what we've been doing now, because the process is of course still ongoing with respect to implementation. So starting with nomenclature, the words we use and the meaning of those words it really have significant meaning for patients particularly. And it really is something that encompasses many things. And it's important the nomenclature really help us in understanding of the disease, that it avoid stigma associated with the disease, that it have also considerations for medical accuracy and precision, of course, and it needs to have clear defining characteristics. Policymakers need to understand the impact of the disease. There needs to be awareness across stakeholders, which we'll get to a little bit towards the end. And we need to have a clear clinical care pathway for patients once they are identified. And then, of course, it needs to be something that is accepted on a societal level, and it can't marginalize groups or individuals. So I guess the first question is, why now? Well, the truth is this disease has been evolving over the last 40 years now, actually, with respect to nomenclature. In fact, in 1980, Jürgen Ludwig first coined the term NASH because prior to that, although descriptions had existed in the literature about the association between steatosis and the presence of diabetes in people who didn't drink or supposedly denied drinking, it wasn't something that was widely believed. And in fact, when he tried to publish this paper, this first report of steatohepatitis, or non-alcoholic steatohepatitis, as he referred to it, nobody would publish the paper. In fact, finally, it was published in the Mayo Clinic proceedings. But this, given how many citations this paper has gotten and how it continues to be referenced over time, it's quite remarkable that he really had such a difficult time getting it published. So since then, the evolution of NAFLD nomenclature has really continued. And as I said, in 1980, Jürgen Ludwig's paper was published, but then in 2002, we had a single topic conference on NAFLD in Atlanta, and we discussed many, many things, among which the nomenclature and what would be the most appropriate name, because we recognized even back then that having a negative term or an exclusionary term was not really appropriate. And then in 2020, in a special issue of Gastro, Mohammed Eslam, Arun Sanyal, and Jacob George published a commentary piece in this issue that proposed the term metabolic dysfunction associated fatty liver disease, and included a panel that was sent a very short questionnaire to sort of help brainstorm acronyms for the disease. And I think that some of the conclusions were actually quite useful. It proposed a name that was affirmative and not exclusionary. It removed the stigma from alcohol, and it recognized the close relationship with metabolic disorders. So these were all, I thought, really good things. But where I think many of us took exception was with respect to the definition of this and the ongoing inclusion of a word that is actually stigmatizing to many people in English. So with this new nomenclature, the new definition eliminated or significantly diminished the importance of steatohepatitis, which we, and we'll get to a little bit what the panel thought about the importance of it, because it's the driving force of the disease that then leads to fibrosis accumulation, which then, of course, is linked to outcomes. But also importantly, it allowed for very liberal alcohol use, which it did identify a sicker group of patients, but for two reasons. One, because it included alcohol without a specific limit, which, of course, we know accelerates the natural history of the disease. And then it also mandated two cardiometabolic risk factors, which could also and did, because it's been studied, select for a more ill or a group of patients that would be more likely to decompensate in the future. So we had concerns over the validity of the process because it wasn't a very open and transparent process, and we were concerned about the impact of the definition change more than anything else. So we wrote a couple of editorials, and sorry about the formatting that looks funny on this slide. So this was what we thought was the best way to approach this would be a multi-society effort. It was really led by ASLD and EASL. And then later on, ALE, INASL, and other societies joined in the process, but the organizational aspects of it were predominantly ASLD and EASL driven. We just selected a Delphi consensus process because there seemed to be the most evidence in a scientific format to help us achieve consensus on something that was actually quite divergent, had a lot of divergent opinion. So the important aspects of a Delphi process are that it's informed by subject matter experts. It's conducted using a very specific, rigorous methodology for which you really do need methodology experts. There needs to be anonymity of voting and reporting of results to minimize the likelihood that there is bias. There needs to be transparency in the process throughout. The survey rounds also need to be combined with in-person discussion, and this helps facilitate consensus building, and it allows us to acknowledge the value of diverse opinions. It assures also that viewpoints are considered and discussed even if they don't reach the consensus threshold. So what we ended up with, again, and this is the process included 264 nominees, and the way we decided to divide that, the proportion of nominees was based on the association member size. There are, of course, many ways to do this, and we discussed this over several weeks, and many of you were probably certainly involved in the process, but there were probably several of you on this call that were also on the steering committee. We ended up having 56 countries represented in the process. Our steering committee is here, and by definition or by intent, these are people who are highly expert in the disease, very well published in the disease. Again, why? Because these were the group of people that were going to develop the questions to be able to give to working groups to then derive the questions that were going to be used in the surveys over time. So I'm going to give you an overview of the process. I'm not going to bring you through the whole thing, but this is a process that took almost 3 years to complete. There were 4 survey rounds. The first 2 rounds were preceding the first in-person conference. As you can see here, there was an evolution of statements, and in the first 2 rounds, about 2,400 comments. Each of these comments was reviewed, collated, categorized, and then used to revise the questions and the statements within the surveys. And then after these first 2 rounds, we had a meeting in Chicago. It was a 2-day meeting with about 130 people, in person and virtual. We had a professional facilitator that had nothing to do with any organization, who does this for a living. And what she did is she worked us through a series of exercises. In fact, it was the first meeting I've been to since I can remember where nobody had their phone out, nobody had their laptop out. It was a very, very engaged meeting, and several of you were at that, and I thank you for that. Then, based on that information that we received from that particular conference, in conjunction with the other 2 rounds, we then underwent the 3rd round, which also received about 800 comments. After this, we had a meeting of the steering committee at the liver meeting in Washington, D.C., and then we held a Pan Society open forum meeting where questions could be asked, and we had full discussion over several topics that were made controversial. And then finally, this informed the 4th survey round, which then led us to the choices of acronym, which I will get to in a minute. So to summarize, we went through 2 basic things. One, are factors impacting the name change. And the next, which I'll get to in the next slide, is factors impacting the definition change. So in the first round, very early on, we determined that there was enough consensus for a change. And I don't know if I mentioned this earlier or later, but the a priori threshold for consensus was 67%, which is a supermajority. Again, this was discussed as well, but most importantly, it was determined before we began any voting. In round two, it was determined that an overarching term would be most useful because it would allow us to incorporate other future knowledge in the field and understand how we might be able to phenotype people in the future, while also including other causes of steatosis that are not what we were referring to as NAFLD. And then additionally, we determined that both fatty and non-alcoholic were stigmatizing terms. In fact, 66% of the respondents thought that fatty was stigmatizing, which was actually a surprise to me. And we can discuss this a bit later as well. There was the consensus to include the term metabolic. This was highly controversial and discussed at several of the meetings. But again, in the end, it did meet the a priori threshold consensus and hence was then mandated to be included. In the fourth Delphi round, we ended up with 3 acronyms that had virtually the same voting percentage. So then we developed an independent subcommittee that included just the chairs from the original steering committee, and I believe one other individual, and the rest were all from the outside, including endocrinology, pediatrics, et cetera. Then with respect to factors impacting the definition, very early on was determined that any patient who consumes what we initially defined as moderate alcohol, which we subsequently referred to as increased alcohol, that exceeded the context of what we would accept in NAFLD, should be considered a separate subgroup because of its impact on natural history. Steatohepatitis had probably the highest consensus at about 95% that it needed to be retained as it was integral to disease progression and the pathophysiology of the disease. There was a majority for definition change early on that exceeded the a priori consensus threshold, and then later on was just a simple majority. And the reason why we ended up conceding to change is because of the change in the nomenclature for it to make sense to have a metabolic name in the disease and have concomitant cardiometabolic parameters to go along with it. And then, of course, then this was further refined for adults and pediatrics. So the requirements set forth by the nomenclature group that was given to the nomenclature for the nomenclature subcommittee were that it convey underlying disease drivers, that it be non-stigmatizing, that it account for the role of alcohol, that it be able to parse out other specific etiologies leading to steatosis, and to be able to adapt to advancements in the field by accommodating disease phenotypes. So the acronyms that we had in the top 3 were MASLD, MSLD, MHS, MAS, and MAS rather, and MET-SLD. And you can see here when the independent subcommittee voted, there was a very significant majority that opted for MASLD. So that's where we are with that's how we got that term. With respect to the equivalent term for NASH, the subcommittee, given the choices of MASH, MESH, and MET-SH, chose MASH with very significant majority. And then with respect to the group that consumed moderate, just for the sake of argument and definition, now we can discuss further what that means in the context of otherwise NAFLD or now MASLD. MET-ALD and MAASLD were the 2 highest. In fact, numerically, MAASLD was higher. However, due to its we didn't want it to be perceived as associated with any particular association, and so the next one was chosen, which was then was MET-ALD. So with respect to alcohol in the context of MASLD, it's of course common in many cultures and countries, not all countries, of course. And it was important for us to try to balance reality without negatively impacting the natural history of the disease. And again, I completely understand why in the original NAFLD diagnosis, this was thought, well, this is a very common thing. It should just be included because you want to be real world. And I agree with that. However, we did need to achieve that balance because we have 40 years of natural history data that would be helpful to be able to preserve. We also wanted to importantly avoid the risk of slowing biomarker development because the presence of alcohol can certainly change the performance characteristics of biomarkers. And we wanted to acknowledge the likelihood that those with more than moderate alcohol use may also respond differently to therapeutics. And of course, this is, for those of us that do clinical trials, this is a very common reason for exclusion. And so this population really was not being captured. So this is the consensus nomenclature, and the final paper, I believe, was published on October 30th. After multiple revisions, this particular figure actually is not in the final document because it includes MASL, or metabolic dysfunction associated steatotic liver, to be the equivalent of NAFLD that we used before. So here you can see that the MASLD is the equivalent term for NAFLD, and it has MASH and MASL within it. I think the most important change in this nomenclature process was the addition of MET-ALD, and this is really turning out to be a really exciting area. There's already drug development focused on it, and a significant amount of interest and discussions with the alcohol community as well. This recognizes the importance of alcohol-related or alcohol-associated liver disease in the differential diagnosis of hepatic steatosis, and hence is categorized also in green. Of course, we were not setting out to redefine alcohol-related or alcohol-associated liver disease, but it certainly is a very important aspect in the differential diagnosis of hepatic steatosis. And then other etiologies, which we refer to as specific etiology, SLD, and notably things like PNPLA3 and HSD17B13 polymorphisms are not included under genetic diseases because they are really disease modifiers. So what we mean by genetic diseases, we're talking about hypobeta-like proteinemia, lysosomal acid lipase deficiency, et cetera. And then a category for cryptogenic SLD, and that would be people who don't meet criteria for the definition, leaving the caveat that they could over time meet criteria because it's a dynamic process. So touching a little bit on the impact of alcohol on cardiometabolic risk, this is really quite impactful. The combination of alcohol as you increase in quantity in the context of metabolic syndrome, you can see on the left, has a very profound impact on the development of major adverse liver-related outcomes. And then in this very nice graph, you can see over on the right, the hazard ratio increases very significantly, particularly in people who are at the highest tertile of weight. So even fairly low alcohol intake can really be impactful from a risk overall. And so for this reason, we thought it was important to make sure that this group was not forgotten, but not included in with regular MASLD. So there have now been several papers that have been published and some that are in production currently. And you can see this is a nice paper published by Mads Israelsson from Denmark, looking at MET-ALD, MASLD, ALD spectrum. And you can see that this is a dynamic spectrum of disease where over time, depending on the burden, the cardiometabolic burden, and the quantity of alcohol intake, you can have a very significant increase on risk of decompensation. For example, ranging from as little as less than 1% to less than 1% to 15 to 50% over 5 years, depending on the amount of alcohol intake. So we set forth for the steering committee, the independent steering committee, requirements for the revised definition. We asked that it be an affirmative set of diagnostic criteria. there was almost a universal agreement that we needed to err on the side of being inclusive. So again, we weren't trying to identify people who were likely to have more advanced disease. We were trying to include everybody or near everybody who was considered to be NAFLD before. Why? Because there was significant natural history data that we wanted to make sure that we included, and because there is still a lot that we need to learn. There are definitely subgroups of disease that we haven't officially phenotyped, and for that reason, it was important to really be more inclusive rather than exclusive. Again, this was meant to also help minimize heterogeneity and specifically be adoptable to future insights, and that's sort of both part of the same thing. So we wanted to be able to in the future say, well, this subgroup who has only hypertension and steatosis, they belong in a different subcategory for X, Y, and Z reason. They have a different natural history, et cetera, and that we hope to have in the future. We wanted to make sure that the parameters that were proposed were simple and they were readily available and easily measurable across clinical practice settings. We thought it important that the diagnostic criteria be aligned with cardiometabolic risk factors that were already well established. We weren't trying to identify new ones or identify ones that we thought could be impactful. We really wanted to stick to things that were already established and accepted in the cardiometabolic community. And then finally, the set of criteria for adults was then taken and then I adjusted for pediatric hepatology for future adoption into the pediatric population. So this is from the paper, actually, but also on ASLD. We have videos, graphics, and other support tools, including this a variant of this decision tree to help walk people through making the diagnosis. You can see the criteria for cardiometabolic criteria are very loose. You basically need to have either a clinical suspicion, which is then corroborated by the presence of hepatic steatosis, and one cardiometabolic criteria. This, as I'll get to in a moment, really encompasses really almost every patient that was previously considered to be NAFLD. These criteria were not made up. They came from very well-accepted criteria set forth by Alberti et al., published in Circulation in 2009. So as Sanjaya mentioned, we've had endorsement from many societies. NASL was one of the early supporters of this process, but we've had actually almost 90 at this point societal endorsements. And of course, we would love more as well. So importantly, one of the biggest concerns from a clinical trial perspective was that the FDA be aligned and that pharma be aligned with this change, because a lot of the changes in the field are happening in these sectors. So this is a screenshot from George Makar's talk at the FDA meeting a month and a half ago now, where he at the very beginning of the meeting outlined the FDA's position on the nomenclature. And so this was, I thought, very helpful. We are in ongoing engagement with both the FDA and the EMA, which is the European Medicines Agency, through the Liver Forum, and would encourage individual countries to reach out to their regulatory societies to try and continue to bring this, move this forward. So we've had really broad support for implementation, and these are just some screenshots from programs from ASLD, NASL, EASL, ALE, that just show on the website how this is being taken up, and I of course didn't include, there have been multiple national society meetings that have also embraced this, so I, which has been very, very helpful. The ASLD webpage has now been translated into Spanish, French, and Portuguese, and we have Mandarin and Arabic in process. And we would welcome any additional help and implementation of other or translation into other languages, and we'd be happy to include those as well. So to just touch on the initial concern that there was going to be sufficient overlap between NAFLD and MASLD, there was, just like there were people on the side of really making it very exclusive and refining the population a lot, there were also people who even took exception to the definition as we had it, which was very, very broad and inclusive. So it was really important to see some of these papers come out demonstrating the very significant overlap. So this is a paper from Vincent Wong and others from Hong Kong, looking at 3 different populations. First, a community sample, the second, an incident NAFLD sample, and the third, a biopsy-proven NAFLD cohort. And then what they did is they applied the MAFLD diagnostic criteria and the MASLD diagnostic criteria. And you can see here that with respect to the community cohort, only 2.3% of those fulfilling the MASLD diagnosis and 5.4% and the MAFLD criteria did not meet criteria to diagnose this cohort that had been previously diagnosed as NAFLD. With respect to incident NAFLD, this I thought was interesting. Only 10% didn't fulfill MASLD criteria, but almost a quarter didn't fulfill MAFLD criteria. And I think the reason for this is that early in the disease process, you may not have heavy cardiometabolic risk burden, especially in younger individuals. And so that's where you're capturing a little bit more of those earlier cases. And then with respect to biopsy proven, again, very minuscule percentage, much less than 1% not fulfilling by MASLD criteria, and 2.2 by MAFLD criteria. Now, there's significant overlap in general with these 2 groups, but there are subtle differences. And looking at again at this these Asian cohorts, there was closer overlapped using the MASLD diagnosis. So, also importantly, the capture of lean, what we used to call lean MAFLD or lean patients with MAFLD or MASLD. There were more left out by the MAFLD criteria. This was one of the other issues with this, is that it really did not capture well enough people with lean disease, particularly located in Southeast Asia and Asia in general. And here you can see an Indian real-world cohort of 1,643 patients with 170 diagnosed as lean. 84% fulfilled the MASLD diagnosis, and just under 50% fulfilled the MAFLD diagnosis. So not perfect, not capturing all, but certainly capturing the majority of these patients, which is important. So with respect to the biomarker population, again, this was something we were really worried about because there are a lot of studies ongoing. We are hopefully very soon to have our first approved drug for MASH. And you can see here, this is a cohort from Vlad Ratsu's group. Actually, he and Jerome Boursier published this from France. And you can see that in those where the cardiometabolic risk factors were available, 98.4% of their cohort filled criteria. And if you look at down below, even for those that had at least one 99.9% of the subjects had, or the people in this particular data set had at least one cardiometabolic risk factor. So it really is a very inclusive diagnosis, which should not have any impact on biomarker populations. And I don't think I have it in this slide set, but both the NIMBLE consortium from NIH is looking at this, and preliminarily there's been complete overlap. And then Litmus also did an analysis, and they have about 98% overlap in the Litmus Consortium in Europe for overlap with the diagnoses. So moving on a little bit to stigma, and this is something that admittedly did surprise me a little bit. I think largely because we don't ask our patients enough how they feel about names, actually. And what I've learned since I've undergone this process is I do ask patients, and they do actually feel stigmatized, again, in English. And there's a lot of variation, of course, with respect to language and culture, whether stigma is perceived, but it really is an important thing that I think we don't talk about enough. So there are lots of different types of stigma, and these are some examples of interventions. So public stigma, there can of course be campaigns to fight against stereotypes. There are social contact interventions by peers. With respect to structural stigma, things like nomenclature change can really help with that, because if we use different language to describe a disease state in this particular setting, then we start changing the way we think a little bit around that. Facilitating access to prevention and treatment is also important to reduce structural stigma. And then in the healthcare setting, social contact interventions and medical and health staff training, involvement of community members to facilitate engagement in care, and then patient empowerment. And we're seeing right now an era of significant patient empowerment with more and more inclusion of patient advocacy groups in at all stages, actually, of medicine. And then there's the concept of self. All these things add to self-stigma. And what this actually results in is care avoidance and delayed care. We see this in alcohol-associated liver disease very profoundly. This, of course, leads to an increase in the number of people with severe liver disease because they're reluctant to seek care or embarrassed about it. It can also increase unhealthy behaviors due to lack of intervention and knowledge, and spillover of stereotypes to unrelated patient groups, and also ultimately increase health and social inequities. So there are multiple barriers to effective care, and now that we're getting into the stage of trying to implement much of this, we're starting to think about these very purposefully. So from a patient perspective, there's low disease awareness, there are disparities in access to care, and there's disease stigma. From a provider perspective, there's really a lack of perceived treatment options. And this has been something we've been focused on for a while because, of course, even though we don't have an approved drug for this disease, we have plenty of options that we know are disease modifying. And there seems to be a lack of awareness among primary care, particularly about this. There's a lack of understanding of how to identify people who are at risk for progression. We hope that the nomenclature change will help highlight the importance of cardiometabolic risk factors, because that is what's driving the risk for disease progression. There's also a problem in the sense that advanced disease often is associated with normal labs, and many primary care, in particular, doctors see normal liver chemistry and say, "Oh, you're fine. You don't have to worry about it." And there's this perception that having steatosis in the liver, fatty liver, is really nothing to be worried about, when of course we know that it is a very important contributor to advanced liver disease. And then again, for relevant to both patients and providers, there's really no specific symptom profile. So with respect to the impact of a change like this nomenclature change on patients, there are lots of advantages. It uses non-stigmatizing language. It allows for a more seamless discussion of root causes of disease. It offers a diagnostic category for those with MASLD and alcohol above the allowable limit, but not enough to meet criteria for pure alcohol-associated liver disease, namely MET-ALD. But the disadvantages are that it represents medicalization of the lexicon, and there's, of course, less familiarity throughout with the new terminology. So there are there's, with respect to practical implementation in patient care, we are really doing a lot, and more can always be done. I encourage all of you to engage your patient communities. We've been trying to do webinars, engaging in partnerships with multiple patient advocacy organizations. These are just US ones because that's really what I've been focused on in the United States, and then ongoing conversations with these patient care groups. There are implications to clinical care. We need to continue to disseminate nomenclature change, and we need to adjust the narrative. There's significant impact on there could be an impact rather on the interpretation of existing data. I think we're now seeing enough evidence that this is not going to be a significant impact. Their disease awareness, we weren't doing a particularly good job with NAFLD, so I'm hoping that this rise in interest on the part of pharma and others will then bolster the dissemination. And then, of course, implications that we just briefly touched on in clinical trials. So medical education, we are working on changing medical textbooks, implementing in medical school curricula. It's really been used very nicely in publications. I don't have a recent tally, but we've already are seeing very significant uptake. Hepatology and JHEP are going to be only accepting the use of the new nomenclature, I believe, starting in January, at least for hepatology. Again, and we're working on increasing use in clinical practice. With respect to higher level adoption, we're actively engaged with regulators, as I mentioned, industry, and then from a billing and coding perspective, we are engaged with the Center for Medicare and Medicaid Services, which is in the United States, to change billing, and the World Health Organization as well to help change ICD coding. So the Gartner plot can be applied to many things, but I can certainly tell you that this is really applicable to the nomenclature change process. As you can see here, there was a trigger for innovation. I don't think we ever actually had inflated expectations because it was difficult from every step of the way, but we certainly had many low periods. It was a very difficult process, but I do think we're finally coming out and starting to see some of the fruits of this effort. So to summarize, the MASL defined population has about a 99% overlap with NAFLD population. MASH is defined in equivalent terms as NASH, so they can be used, they can be superimposed. There's really been excellent uptake, ongoing efforts to include this and incorporate into ICD coding. And Met-ALD, I think, is the most exciting part of this. There are common mechanisms to suggest pathways to target both diseases simultaneously. There are challenges, of course, to quantifying alcohol intake and weighing the relative impact in the context of MASH or NASH. And this is what needs to be worked on with future developments. Emerging therapies, such that those that reduce craving for alcohol and sweets, seem promising. And then there are genetic approaches that are also going to be very applicable to both populations. So we're going to continue to work on all of these things, increase dissemination and use of the terminology and the definition, and continue with our campaign to increase awareness and adoption, which needs to be both grassroots and society driven. And with that, I'd like to thank really Phil Newsome more than anybody. He was my partner in this process, the governing boards of ASLD and the staff who really provided all of the support. Jeff Lazarus and Diana Romero, who are experts in Delphi methodology, and they were instrumental. The SLD task force of the ASLD, and then the leadership of Isel Ale, and of course, many other societies, including in NASL, who really helped us adopt and make this a global process. So with that, I will thank you for your attention and take any questions that you may have.